Thank you to thank you. Have another chance to have to listen to the professor's excellent presentation, and in the professor's presentation, and I learned a lot about how to choose ALK TKI for those advanced non-small cell cancer. And for those panel discussion, the first about the first question, it's very difficult to in China to change the third generation TKI ALK TKI because if the patient didn't recurrence after first line treatment, and the insurance will not cover the third generation TKI except those patient those patient can't tolerate the side effect of the first generation or two generation ALK TKI. And I think for those advanced lung cancer patient achieved TKI, and if the patient have the complete response in the radio in the clinical, and those patients may be considered a form of clinical cure. But if the patient still have the tumor, those patients just can treatment as a chronic disease rather than clinical cure. And as a overall survival continuing to improve, we would face a lot of different conditions for those patients. And I have a patient with ALK, advanced ALK non-small cell cancer, but he doesn't died from non-small cell lung cancer, but died the second primary cancer after the 4 years treatment of ALK TKI lorlatinib. He suffered from bladder cancer, and after half year treatment of the bladder cancer, is unfortunately he died from bladder cancer. So for those patients, maybe we should also to face this patient have the second primary cancer. And I just think that as a development of the treatment regimen of the EGFR mutation non-small cell lung cancer, the success of the FLAURA2 demonstrated that if we add chemotherapy for those EGFR mutation patient, and the survival will be improved because the adding of the chemotherapy. I think if in the future this treatment regimen would also be used in ALK positive non-small cell lung cancer, and if there are some clinical trials will be being designed or just is practicing in America. Maybe I should repeat my question.
No, I understand. I mean, the first one is if the reason you can't use lorlatinib is first line is because the insurance, there's nothing I can do. But if you have the equal choice of getting lorlatinib or alectinib, then lorlatinib is best. I mean, this is the data. There's, we debate about FLORA2 and Mariposa, who is better. We look at Asian subgroup, blah, blah, blah. But look at the PFS of lorlatinib versus the second generation. There is no debate. There shouldn't be any debate. But insurance questions always a problem. But I thought lorlatinib is already within the national reimbursement system, and if not, then Pfizer should do a better job. And the second question about the patient dying of any other cancer, this is exactly what we want to do. Is people live a long life and they will naturally die of other something else. And I told my patients who is in the 50s and 60s, I started lorlatinib, don't worry about lung cancer because you lived a long life and you died of heart attack, stroke, car accident, and things like that. You won't die of ALK-positive non-small cell lung cancer. But that is exactly what our goal is to have them live a full life, and whatever they will pass from, they will pass from. So I think that's something that that's the goal. I think a lot of patients on lorlatinib will die of something else because it's essentially a duration of a cure. As far as adding chemo, I mean, the thing is, lorlatinib is good enough. I mean, what is the purpose of adding chemo? The overall response rate is high. ALK lung cancer is different than EGFR lung cancer. ALK lung cancer, the median PFS now we are reaching more than 60 months. The osimertinib with EGFR at best 19 months. Add chemo, 29 months of PFS. 29 months of PFS, almost all the second generation ALK TKI can reach at this stage. So it's a little bit different. EGFR has a long way to catch up with ALK positive lung cancer. So adding chemo to that, I don't think maybe will knock off some of the intrinsic resistance, may be good, but I don't think the incremental gain is already less. And if there's such a hard time starting lorlatinib, whether you don't believe it or because of insurance, adding chemo to lorlatinib, it's not really something that is practical. So I mean, the key is everybody should start with lorlatinib first line, and then we can go on from there. That's my. I mean, I spent my career, at the ALK positive lung cancer. We had crizotinib. We were so excited. It was a miracle. We know the results 1 year ahead of everybody else in the principal investigator call. 6 months later, everybody relapsed. I mean, we gave them so much hope, and then we took them away, and took that hope away in 6 months. It took us a long time to get to lorlatinib where we can get to a PFS of 10 years. We have so many patients die, and if they had started lorlatinib, they'll still be alive. So for those of us who have started from the beginning, starting second generation is really not acceptable. It's really not acceptable. A lot of younger generations, they don't know, they haven't tried to just look at it and say, well, 29 months is it's good enough, maybe. But that's not, that the projection of lorlatinib will be so long that, maybe Pfizer may not even have the patience to follow up. But we came a long way. EGFR, we still are hitting at 19 months, so after all these years. But ALK is going up to more than 60 months, and it's a little bit different. And so ROS1 is longer than EGFR TKI. We don't add chemotherapy to ROS1. So I think the key is to really try to convince everyone to start lorlatinib first line. Don't have a treatment holiday, and then we should be able to. And those patients will die of something else, unfortunately, but that's a natural history. You die of old age, you die of Alzheimer's disease, you die of accident and all that, but he won't die of ALK-positive lung cancer. That is what's happening. So I will stop here.
Yes, thank you for the excellent answer of the professor. Thank you.